Hello and welcome to the programme from me, David Foster. Now, here is a question. If we are all in this together, as we're being told, why are so many people from Black, Asian and minority ethnic groups dying with coronavirus? There's to be an inquiry in the United Kingdom, but let's have the conversation now on Roundtable. More exposed frontline workers than other groups, poorer health, poorer housing, all cited as possible reasons. Are there other factors, though, that expose BAME communities so brutally to such a terrifying disease?
Another victim of this deadly illness, another victim from an ethnic minority. Mervyn Malley Kennedy was 67 years old, a bus driver in London and father of 3. Black and Asian people are succumbing to this silent killer. Mervyn is amongst now more than 20,000 dead in the UK since this outbreak began, and the signs suggest Black and Asian people are being disproportionately affected by COVID-19. But the question is why? Socioeconomic factors are thought to play a large role. People from BAME backgrounds disproportionately work in jobs where there is a higher risk of being infected, including working on the NHS frontline and care homes, as well as taxi and bus drivers. Despite only accounting for 13% of UK population, many BAME people are key workers on the front line. 44% NHS doctors and 24% of nurses are from Black and Asian minorities. The same seems to also be the case in the US, where the African American community seems to be the hardest hit. 33% of those hospitalised have been African Americans. In the UK, the government has launched a review into the number of deaths among minority communities. Finding the answers could be a matter of life or death.
Okay, let us look into this with our experts on this round table. In a little while, we'll hear from Mohammed Abbas Khaki, who's an NHS doctor working in a hospital accident and emergency department, also from Dr. Tracie Collins, a vascular specialist who's been looking at racial disparities in her medical field. She's in the United States. But first, we say hello to Dr. Hina Shahid, a family doctor here in the UK, who's chair of the Muslim Doctors Association, and Jason Arday, professor of sociology at Durham University, who believes that social and economic barriers make it harder for some people to protect themselves from diseases such as coronavirus. Good to have you with us. Hina, you first of all, you're working as a general practitioner, a family doctor, and you are concerned about the fact that you're exposed to this whenever you go in. What is happening to you?
So it's obviously a very rapidly evolving situation, and every week has been different, if I'm perfectly honest. We started off with no real kind of guidance in place about what we should be doing, how we should be protecting ourselves at work, ways of working. We were, well into March still seeing patients. We didn't have the adequate protective equipment. We were putting ourselves at risk when we were going into work, and also putting our patients at risk as well by potentially being super spreaders. We're still in a situation several weeks down the line where many parts of the country, both in general practice and in hospitals, don't have the adequate protective equipment that they need. We've seen, unfortunately, doctors and nurses dying. The overwhelming majority, over 90% of doctors who have died have been from a BAME background, which is really concerning. And then we've also...
Well, we're going to go into that in just a little bit, because I've got some figures, and I think Jason has a slightly different figure in mind. But I want to ask you, Hina, are you particularly worried because you are from a BAME community?
Yes, absolutely, both as a doctor and also as a citizen. So as a doctor, I've mentioned, more BAME doctors have died than other, ethnic communities. But also from a general population perspective, since the beginning, I know so many people personally who have been affected by coronavirus, admitted into hospitals, relatives of friends who sadly died. And it's been a constant theme right since the beginning. Whereas when I speak to my non-BAME colleagues and friends, they don't have the same stories and experiences.
But can I just try and pin you down on this one? Why do you think BAME communities, because I wouldn't say you were affluent, but you're from a middle class, relatively wealthy background. You are a family doctor, you get well paid. Why do you think so many doctors, many of whom would be in the same social bracket as yourself, are succumbing to this disease? Can't be poverty.
Yes, absolutely. So that is a question that we're trying to really look into. So at the moment, we don't have enough data. We don't know much about these doctors. But actually, what we do know is if you look back 20, 30 years, there's been a consistent history of BAME doctors experiencing discrimination at work. This is well documented. And what this can do is erode somebody's sense of self-worth. And actually, it's now being thought that this might be one of the reasons why BAME doctors have been disproportionately affected, is because they have felt uncomfortable to raise concerns about, for example, lack of protective equipment that I mentioned at the beginning, and have been put into challenging situations at work, which was not safe for them to be in.
And I want to show you something on the screen, particularly the people who are watching this program, but you'll hear what I'm saying, you two. This is from the Intensive Care National Audit and Research Centre, who state that 35% of almost 2,000 patients in intensive care units were non-white, which is almost 3 times the 13% proportion of the whole UK population. 14% were Asian, 14% were black. And here's another one. This is from the Health Service Journal, which says it is for healthcare leaders just a couple of days ago. The deaths of more than 100 NHS staff have been analysed by 3 leading clinicians. It says 19 doctors, 35 nurses, 27 healthcare support workers, 25 other staff, and 63% were from BAME groups. Now, I know you said it was 90 plus, Hina, and Jason, you think it's around about 75%, but it is a higher proportion than normal. How come social factors with health professionals, Jason, come into this when they are relatively affluent, and you couldn't say that they were facing grinding poverty?
One of the things that's I think is really interesting about this phenomena is, yes, you could argue that from a capital perspective, in terms of, I guess, socioeconomic status, these particular professionals are in a very privileged position if we think of the financial aspect. But what I would say is that what we are aware of is that there is over 50% of frontline NHS workers are from BAME backgrounds. And I would argue that that would obviously place them more at risk of, potential diseases or being at threat to these types of things.
So it isn't necessarily their socio-economic position. It isn't necessarily anything physiological. You believe it is perhaps because people don't go to traditional medicine quite as much. They're a bit worried about the procedures and so on and so forth. We're not just talking about medical professions. We're talking about people from the wider BAME community here.
No, if we talk about the wider BAME community, there is a huge socio-economic deficit that places them more at risk of COVID-19. So, for example, we know that there are institutional factors that are aligned to racism around employment, around housing, around access to the judicial system, around access to the welfare and benefit system that massively and disproportionately disadvantage individuals from BAME groups, which obviously mean that in terms of, for example, observing something such as social distancing, what we do know is that obviously not having those kind of instruments at their disposal doesn't allow them to observe social distancing, which obviously...
What you mean, because more people could perhaps live in multi-generational households, many more people in a particular house. That not necessarily put upon them by society. That is in some cases a choice.
No, I'd have to disagree with you. I wouldn't say that is a choice per se. I mean, in terms of the idea of social mobility, what we do know is that there are, BAME groups who engage in kind of social mobility interventions, such as, for example, education, so getting educated to university standard. But we know that factors such as institutional racism stop individuals from progressing and being socially mobile in society. And
Yeah,
that
no,
does
I do get that. I do get that. But I'm saying, well, let's go to Hina for this one. Asian households, an awful lot of multi-generational families living out there together out of choice or only out of necessity, would you say?
There is an issue around social mobility, and also we have to look at the broader social structural factors. So if people are struggling with employment, don't have enough income, then you will, and we know from data as well that if you're from a BAME community, you're more likely to live in overcrowded housing, and that makes social distancing difficult. So there's that element as well. If you can't afford to live separately, then you don't have much of a choice but to live in multi-general households. Yes, of course, there is
but why the
that cultural element.
Why the prevalence of heart disease, diabetes, high blood pressure, obesity, asthma in BAME communities? That must be one of the reasons why, unfortunately, so many people from that group are succumbing to this disease.
That's part of the reason. So, there are several reasons. So there are structural and social factors. There may be cultural, religious, linguistic factors, and also living conditions. And as you mentioned, physical and biological factors that might be putting BAME communities at a higher risk. So if we
can I tackle you on this one? As a doctor, by biological conditions, do you mean a prevalence?
So
I don't mean a prevalence. I mean you're much more likely to get these conditions because you're from BAME. I don't know.
Well, this is really interesting because there may be a genetic component, but what we know is that 80% of health outcomes are socially determined. So, where you live, where you work, how you work, your employment, all of those things contribute much more to health outcomes than physical or genetic characteristics. So there may be a genetic predisposition in BAME communities to experience higher levels of heart disease, and obesity, high blood pressure, all those things that are linked with a poorer outcome in COVID.
Jason, you talk about structural institutional racism, not giving people the chances, perhaps, from these communities to access healthcare and social mobility, etc., etc. Are you satisfied, A, with the government inquiry which has been launched, and secondly, with the one by the opposition, the Labour Party, which will have Lady Lawrence, Baroness Lawrence, Stephen Lawrence's mum, as part of it?
To say satisfied, I wouldn't. I mean, it's fantastic that an issue such as that is situated around, racial inequality has been moved from the, political margins to the centre. But I think a review would be more beneficial than an inquiry. And Yvonne Field of Ubele Foundation has done some fantastic work around this and mobilising a BAME COVID-19 bereavement fund. And one of the points that she was making in a broadcast a few days ago was this idea that, an inquiry is almost, an intermittent thing. It's going to provide instant questions, which, not necessarily provide the answers that we may need.
So you're saying something needs to be instituted that monitors this in the longer term, yeah?
So there needs to be a longitudinal intervention, and I think a review would be better because it allows us to gain, data from in a mobile sense in terms of data is changing all the time, and it allows us to engage with this in the public vernacular for a longer period than effectively what would be, a snapshot. And I think a lot of times inquiries can be snapshots. They don't provide you that longitudinal picture.
We've done enough. Yeah, I get it. Thank you very much indeed, Jason Arday there. Thank you for taking part in this part of the roundtable. And Hina Shahid, who's chair of the Muslim Doctors Association. We appreciate very much what you are doing, and good luck with all of what you are doing as well, Hina. Thanks for being with us today. Time to bring in our other guests on this roundtable, Dr. Mohammed Abbas Khaki, who's an NHS doctor, a family doctor, as well as working in an accident and emergency department at a London hospital, and Dr. Tracie Collins, Dean of the University of New Mexico College of Population Health, who is a vascular specialist looking at racial disparities in her area of expertise. Great to have you both with us. Tracie, you're in New Mexico, but I'm going to ask you about figures for the whole of the United States because you've got some quite startling numbers.
Yes. So unfortunately, COVID-19 has hit racial minorities quite hard. And we've seen it with the Navajo Nation here in New Mexico, and certainly around the country for African Americans and Latinos. We know for African Americans that in Michigan, they make up 15% of the population, but they represent 35% of those diagnosed with COVID-19. And while the overall death rate from COVID-19 in Michigan is 6%, African Americans account for 40% of those deaths. In contrast, non-Hispanic whites represent 25% of COVID cases and 26% of deaths. So some stark differences. Similarly,
do you want to have an educated guess at why that is the case?
So multiple factors. There's a higher rate of chronic conditions in minorities. We've got asthma, there's hypertension, diabetes, obesity. These are all known risk factors for poor outcomes with COVID-19. But those aside, there are also things known as the social determinants of health. Those are those upstream factors that influence health outcomes that relate to employment, housing, food, social justice. So minority groups are typically marginalized across the board, certainly here in the US. And so employment opportunities are not always optimized. And these are the people who are working what we also call the front lines as essential workers, food services, public transportation, warehouse work, and they don't necessarily have access to the appropriate barrier method to prevent them from transmitting this virus or contracting
Tracie, I'm going to go into something in just a moment that two members of the House of Representatives have said. But first, Mohammed, let me come to you, working in an A&E department as well as being a family doctor in North London. Now, you've spoken about the cultural side of this. The fact that, for example, let's say there's an elderly person in a BAME household who just doesn't get that he or she should go to hospital, worried about it, and therefore puts themselves more at risk, yeah?
Absolutely. I mean, there are clearly issues with communication. Patients who don't have English as a first language are finding it a bit more difficult to access the information or process the understanding around physical distancing or when to seek and access medical attention. Now, the other thing, of course, was in that sort of group is the cultural reliance on alternative medications or faith as a method of healing. And of course, there are other things at play. So countries of origin where alternative sources of information are given and the propagation of fake news is something else that we are seeing as well.
Okay, I'm going to go back and mention these two members of the House of Representatives in the United States. You've spoken about the social side of it and the cultural side of it, but they are also talking about an institutional side to this. Representative Ilhan Omar. This is what she put out there in a tweet. As my sister at Representative Presley says, when the rest of the country catches a cold, Black America catches pneumonia. The crisis is laying bare inequalities that we have neglected to address for decades. And she went on to talk about Milwaukee, Wisconsin City, which has a reputation for being the country's most segregated. 25% Black community, 73% should say, of COVID-19 deaths. Tracie, is it institutional as well as you say cultural, perhaps?
Absolutely. We have issues in our country with institutional practices, cultural representations, but also the other norms that make it certainly favorable for the majority to thrive and the minorities to suffer. So it is certainly structural racism, and we're not going to fix this in a day. What COVID-19 has done is highlight how much inequality exists in our country and why this is so devastating for minorities. When you don't have housing that's appropriate or air quality that's appropriate or access to quality health care, those are systemic things that have been in place for years, and now they're coming to the forefront. Yeah.
Can I throw this one at you? We mentioned this in part one of the program. An awful lot of the frontline workers who have died in the United Kingdom, I think it's the same in the United States, our doctors and nurses, and an awful lot of those would not be said to come from the less well-off areas of society. Doctors would be affluent, middle class. Is there anything physiological going on here? Anything to do with the makeup of the body, genetic makeup?
We know that we know that patients who are from the BAME population genetically have more of a chance of having diabetes, kidney disease, heart disease, vitamin D deficiency, and all of these can contribute to having a weaker immune system. So, of course, there is that element at play. But of course, within that BAME population, as mentioned, there's the living in multi-generational households. So if you're a frontline worker in a key worker role who's got these predispositions, who's then going back to live in these situations, it's not surprising that we see more of the BAME population in intensive care units.
Tracie, what is this unconscious bias that you have referred to in some of our correspondence between our producers and yourself?
Yes, it's the approach to someone who looks different than you or comes from a different background, and it's not overt. It's just an assumption that this person has certain qualities, characteristics that make them different from you, and there's an implicit sort of hierarchy that you establish. So let's say that as a physician, for me, taking care of patients, and after taking care of maybe 10 patients in a day, I'm going to quickly assimilate, once I sit down with the next patient, kind of what I anticipate the risk factors will be, the social status. And it's not something that I'm directly using as far as negative, but it's occurring in my thinking. And it's so subtle, and we all have it. The unconscious bias perpetuates those factors I mentioned earlier, the determinants of health. It perpetuates the impact of those determinants on underserved populations.
Can I just ask you this? Do you think there's anything physiological, anything genetic here?
Mohammed, I agree with you that there are genetic components, but largely race is a social construct. So when you think about the people like African Americans having a higher rate of hypertension, diabetes, obesity, what drove them to have those risk factors? Largely, it was racial inequality. It's not purely the genetic. The genetic piece is that we have histories or our families. So there's the family cycle. So your grandfather went through this, your grandmother went through this, your mother went through this, and now you're going through this. We label it as genetics, and there's a small component of genetics impacting health outcomes, but largely 60% at least are related to social determinants of health. And that includes the development of chronic conditions like hypertension and diabetes.
Well, I certainly would echo some of the sentiments that Tracie says. You know, all of this is multifactorial, and that's why we're looking at doing research into it. We know for sure that race plays its part, because we know that if you live in a more deprived area, we know that you have a shorter life expectancy, you have a general poorer state of health. And of course, we know that most of the BAME population live in these deprived areas. So we've got the cultural element, we've got the social element, we've got the inequity element of accessing healthcare. And of course, we also have the genetic and the frontline component. And that's why it's so important that we actually get an inquiry into what's happening into...
But it isn't necessarily COVID-19 that's causing this in any way. Do either of you think that its particular nature is making life much more difficult in these circumstances for people from BAME communities? It's not the disease itself. Mohammed, you first, then Tracie, if I may.
It's really hard to say, because we're just learning so much about this disease every day, and guidelines and how we interact and presentations and symptoms are evolving daily. So it's impossible to say categorically that this is not just the fact that COVID-19 targets the BAME population, but we do know that there's already a preponderance, already an existing number of risk factors that BAME populations have. Definitely the inequalities in healthcare being exposed at this time, which makes them more susceptible to COVID-19.
Tracie, it's not the disease itself, it's the people who are suffering.
Well, COVID-19 is, as Mohammed pointed out, we're learning so much about it. It is a devastating virus. And we're learning now that younger people might suffer with cerebral vascular disease, have a stroke. And so why would a 30-year-old end up with a large vessel stroke? What is going on with this virus? So there's things about COVID-19 that make it devastating. Its impact on the minority communities is highlighting inequalities that we've had in place for years, and their risk factor profiles, how we really have to go back and figure out how do we improve healthcare access and other issues that would actually improve the health of these marginalized communities.
Listen, thank you. Thank you very much indeed. That's Tracie Collins joining us from New Mexico, and Mohammed Abbas Khaki, who's in North London, both working in the medical fields and facing this not just from a personal point of view, but also from a professional point of view. Fascinating to have you both on the program, and big thanks to our other guests as well. From me, David Foster, that is it for now. We will be back with more programs about the world under coronavirus, the ripple effects of this terrible disease, this pandemic. From me, goodbye for now, and thank you for watching.